just found out that our screen was not changing. So let me maybe go back a little bit here. And really, this is where we started. So again, the Recovery Act was the first stage that introduced meaningful use. Here's the 3 different stages that defined as, the goals for the program. The 2010 was when the actual stage 1 was released, and here's that simplified calendar of what that included to be in each stage for 2 years, and again 2015 not being determined at that time. And then when stage 2 final rule came out, it did not come out until September of 2012. So again, originally as it was defined, we were supposed to be in stage 2 by be upgraded and ready to roll for stage 2 for an entire calendar year by January of 2013. So that late release of the 2002 requirements pushed back stage 2 until 2014. So people that started in the first year in 2011 were granted 1 more year of stage 1. But again, they continued that trend of you were to be in each stage for at least 2 years before moving on to the next stage under those definitions. That late release of information kind of created the perfect storm because there was quite a snowball effect of that. Even though they moved back the date till 2014, it still shortened the amount of time that vendors had to work on the developments to meet those requirements and to get through beta, which was also more stringent, and get certified. And it created this backlog of vendors that were trying to get certified. So even their systems weren't able to get systems certified quick enough in order for products to be released. So it resulted in a late release of products certified for stage 2. So into 2014, the year that we were supposed to be in stage 2, even with that delay, there's still many providers were finding that there still was not enough time to install, implement, and train on that, which then introduced the flexibility rule that we got in September of 2014. In that flexibility rule, they pushed back stage 3. So again, we were still in this process of we would be in each stage for 2 years. Whenever we started, we would start in stage 1 that had like a less stringent requirements, and then we would move to stage 2. With that flexibility rule, they did allow flexibility for 2014 only, a 90-day reporting period that would allow providers to either attest if they were not able to fully implement the 2014 edition of the certified EHR. It would allow providers to attest 1 more year under stage 1, or they could move on to stage 2. So I think by and large, most of our practices, we did have a few that attested for stage 2 last year, but most of our practices did use that flexibility rule in order to meet requirements for 2014. So when they opened up the comment period for that flexibility rule before it was finalized, one of the biggest complaints that they got was that even with the amount of time left, providers still did not feel like it was possible to be upgraded and ready to fully implement for an entire year's worth of reporting for 2015. So many people were pushing for a 90-day reporting period for 2015. However, CMS's response in that final rule was that they were not going to give any special reporting period for 2015, that was 2014 alone. So it was made final, and they weren't going to even consider any changes. But within a few weeks of that final rule being released, there was quite an uproar about that. So even by September 16th, Renee Elmers was already introducing an act that, called for a 90-day reporting period for 2015 to give providers a little bit more leeway, because she felt that, as many of probably you did, that the flexibility rule was a little bit short-sighted. In response to that, in January, CMS announced that they intended to engage in rulemaking. So they were considering shorting the 2000 reporting period to 90 days, and they were also considering realigning it with other programs, as well as modifying aspects of the program. So they announced in January their intent. We were all holding our breath, waiting to see what was going to happen. by April, they finally released the proposed rule, and we were on top of that, reviewing that. I even got on and made some comments regarding that. I hope many of you did as well. They opened it up for a 60-day comment period that ended back in June 15th. And again, we waited. I know many of you have been anxious to know what was going to happen for 2015 in regards to meaningful use. So finally, months later, this month, we finally received the final rule. So that's really what we're going to focus on today. I know for some of you this may feel like, hey, this is so late in the year to get this, and we, of course, feel that same way, but I just wanted to kind of review that to see what got us to this point that we're at today. So, and that's what we're going to cover is the changes, because they are somewhat drastic, some of the things that have happened. So key points from this is that stage 1 and stage 2, as you knew it, are gone. So that we'll talk about what that means. The good news is there are no new requirements for you. So overall, the program itself has been simplified. They took out measures that they felt were redundant, duplicative, or topped out. And as it stands today, all providers are required to attest to a single set of objectives and measures. So they've done away with they've done away with, again, stage 1 requirement if you're starting your first year, and a stage 2 requirement. Everybody attests to the same measures regardless of which year you started. That is now referred to what they call modified stage 2. So there's only 10 objectives now. So again, regardless of which stage you were in or scheduled to be in this year, you're only going to have to attest to 10 objectives. They've also simplified it. I know this was a point of confusion all the time when we were trying to train and help people, that there's no more core set and menu set objectives. So there's just objectives. So you're not going to have to deal with the whole menu set in the way that we knew it before, which was often confusing for people. They are, however, even though they've done away with stage 1 requirements and stage 2, they've combined them so that we have this one set of objectives. They are allowing exclusions for providers who were previously scheduled for stage 1, because as you can imagine, the 10 objectives are going to be more aligned with what was required for stage 2, which really just built on stage 1. So understanding that we're late in the year this year to get this information, they're not expecting providers that were scheduled for stage 1 and have been working towards that this year to have to meet all what was formerly known as stage 2 requirements. So they are providing exclusions if you were scheduled for stage 1 this year. So they have also reduced thresholds for patient engagement or action. And I know that was a big pain point for a lot of people because, you could do everything you could in your practice, but many of you felt like, I can't make my patients get online or send me a message or things like that. So they have heard that, and they have reduced the thresholds on that. And then the good news is providers, and hopefully you already have, and I know that many of you have, you've continued to do what you were scheduled to do for this year. You've just been holding off to see were we reporting for a whole 90-day or for a whole calendar year or 90 days. That's what many of you, the boat that you were in. So the good news is if you've already been working towards stage 1 or stage 2 this year, you're going to find it easier to attest. So because they've simplified the program, if you were already meeting the requirements that you were scheduled for, there really should be no reason why you shouldn't be able to attest for 2015. So when we say that they've done away with the stages, this is again is a look at the last calendar we had from last year before all this decision was made. Again, you were scheduled for a stage, what was formerly like a stage 1 requirement was different requirements than if you were moving to stage 2. They've done away with all that, so a new definition of stages. We still have to use the word stages because if you look back at that original intent from CMS to increase the, to progress in interoperability and data exchange and things like that, they are still moving towards that and building upon that. In fact, with this final rule, they have released the requirements for stage 3, which I would encourage you, as you have time to go and review, because they are going to open up a 60-day comment period for that as well. So if there is anything that you feel passionate about in what they're proposing, make sure that you get on and make comments about that so that you can influence the final rule for stage 3 as well. So as you can see, looking at the calendar now, it does not matter when you start. You're not starting in stage 1 as we used to know it. You're starting in what they call the modified stage 2. So regardless of when you start, everybody this year has the same 10 objectives to adhere to. The only exception to that is that you can see if you started in 2014, or if this is your first year, then you really were scheduled for what the old requirements were for stage 1. So in many cases, those requirements haven't really changed. Maybe the thresholds increased, but there is a little asterisk by the modified stage 2 for in 2015. So if you were scheduled for stage 1, you are going to be allowed a certain additional set of exceptions, or maybe lower thresholds on some of the measures that are being required. So there is leeway for you that you don't have to meet what you would have had to meet if if they had just said, no, you have to meet stage 2. Although I do still have a little asterisk for if you were scheduled for stage 2 in 2016, it really is very minimal, the leeway that they're giving you in 2016. They expect that you have enough time at this point to get ready for requirements and to meet them in 2016. So although there are still some exceptions, they are very few and minor. So really, by next year, they expect everybody to be fully adhering to and attesting to this modified stage 2 of 10 requirements. And then you can see when it comes to 2017, you can either choose to attest one more year for the modified stage 2 requirements, or you will have the option of attesting for the stage 3 requirements. They are, because stage 3 was originally slated for 2017, they are allowing providers to still go ahead and test for stage 3 in 2017. And of course, that's as it stands today. I can't imagine that there's not going to be other changes going on throughout these coming years, right? And that's really one of the reasons why I just want to focus on, 2015 and 2016 for sure, to make sure that we're ready and prepared for that. The good news is that the certified EHR technology does not have to be recertified to accommodate these changes in the reporting. So the product that you have installed today, if it's 2014 certified, then you are good to go, and you should be able to attest with that product all the way through 2017 as it stands today. What it does mean, though, is that if you are not on the latest version, you have to be on the latest version in order to attest for 2015. In 2014, they did allow you to attest if you were still on what they call the 2011 certified version. That flexibility is gone. They are requiring that you're on the 2014 version in order to attest. So, and then again, coming to in the future, they have defined the certification requirements for stage 3, so that will be what they refer to as the 2015 certified program, which will not be required until 2018. All right, so how have the reporting periods changed? For 2015, they did finalize that all providers, regardless of what you were scheduled for this year, must attest to any continuous 90-day reporting period within the calendar year. So you can pick any continuous 90 days to attest for this year. Of course, we're already into this last 90 days, which is why I think there's been some frustration over the late coming news on all of this. But again, if you've already been working towards meaningful use this year, you should be in good shape. So in 2016, and this is important to remember, especially if you were scheduled for stage 1 this year and you are going to test for stage 1 this year, you only have a short amount of time. I mean, we've got like 2 months left in order for you to be ready to fully implement for 2016, because everybody, if you're a returning participant in the program, must attest for an entire calendar year. So January 1st, 2016, you better be ready to attest to these same 10 objectives without the alternate exclusions in many cases. You know, if this is your first year. So again, as we look at the objectives today, consider that you need to have everything in place by January 1st, 2016 as well. All right, and then the only exception again to that would just be if your first time participating is going to be 2016, which means that you can choose any continuous 90-day. And then the same rule goes for 2017 if you're a first-time participant, any continuous 90 days. If you're a returning participant and you're choosing to attest for modified stage 2, then you are going to attest for a full calendar year for 2017. Otherwise, if you choose to move on to stage 3 in 2017, then they understand that you're going to need some time to implement and train and make modifications to your workflow and everything else. So if you choose to attest for stage 3 that year, then they are granting a 90-day reporting period just for 2017. All right. When it comes to actually doing the attestation, there's no new requirements on that. We're going to continue to use the current method of attesting for meaningful use through the registration and attestation website at CMS, unless, of course, you're participating in Medicaid, and then your individual states will have their own websites for you to attest through. It should be noted right now that I think a lot of people have been super excited that, hey, now we get the 90 days. I've already got 90 days that I've done meaningful use for this year. I'm ready to attest. Well, because of all these changes, they have taken the attestation website down in order to update it to accommodate all these changes. So you will not be able to attest for 2015 until at the earliest January 4th, 2016. And then you will have all the way up until January 29th of 2016 to actually submit your attestation. I do want to encourage you you can still go register to attest and everything right now. I know in my experience that we've run across things as we've been working with providers where we can help you with, like, if you have questions on, which measure goes with which report and that type of thing through your attestation. But I've had providers that have gotten all the way to the end, they've got all their information in, and then they find out that there's an error with maybe one of their numbers, like one of their identification numbers that they've registered with CMS not matching what they've got for their attestation. So I would encourage you to not wait till the end. Try to attest as soon as you possibly can, because if you run into one of those scenarios, you are going to have to contact CMS in order to get it resolved. So just in order, just be aware of that, because I'd hate for you to be at the very end of the day on February 29th with all of your information and your, attestation ready to go, and then the website fail you because there's something about your registration itself that doesn't match CMS's records. So again, try to go and register for your attestation and confirm all that stuff ahead of time and attest as soon as you possibly can, knowing that you're not going to be able to start until January 4th. All right, so just a little reminder that part of the EHR program is the whole carrot and stick thing. So if you are not participating in EHR, if you decide you're not going to participate this year, for Medicare only, you're going to be subject to penalties. And again, because for 2015, we actually can't submit attestation until 2016, the penalties are always, they're always going to be 2 years behind. So you can see that if you choose not to attest this year, then you're not going to, you will receive a 3% payment reduction on your Medicare from Medicare in 2017. And then again, if you choose not to attest in 2016 or you don't pass your attestation, then you'd be subject to a 3% penalty in 2018. So if you hadn't participated last year, then 2016 is when you would get your 2%. If you hadn't participated back in 2013, then you've probably already been experiencing a 1% reduction this year because this was the first year that they introduced the penalties. So if you are a first-time participant in 2015, you can still avoid 2016 and 2017 of payment adjustments by testing for 2015. If you've attested before, then you must successfully test in 2015 again to avoid it in 2017. They are going to be opening up hardship. They won't open that up until sometime in 2016. So if for whatever reason you're not able to attest this year, and they have made new exceptions that you can consider, like extenuating circumstances. They believe that the late release of information may qualify for extenuating circumstances. They do look at those on an individual basis. Then they will open up a time for you to apply for hardship in 2016. So even though you might not get the incentive money, you can still avoid the avoid the payment reduction. And then as other news goes, when it was released, they also announced that the penalties for 2018 for the EHR program will stop. So you will not get any under the EHR Incentive Program. They will no longer be penalties starting in 2018. Starting in 2019. However, the reason why it's stopping is because 2015 they have now introduced the MACRA Act, which is really going to absorb a lot of the programs as we know them today. So MACRA will have its own set of penalties, but again, I guess in their efforts to try to simplify things, because right now you may also be aware that there's the PQRS program that you also must attest to, and if you're not participating in that, there's penalties for that. That will also end. So they're trying to combine all these little separate programs that may be hitting you and put them under one. And under MACRA, EHD, meaningful use will be a requirement for that particular program. So anyway, that's something that you can look up and find a little bit more information about, but just wanted to throw that out there so that you're aware that that's something that's going to be coming as well. All right, so the good news, again, the objectives that have been removed. So this, again, is a combination of objectives that may have been a part of Stage 1 or Stage 2 that they have found were, redundant or duplicative or simply topped out. So these ones you will no longer have to attest to as part of your attestation. You don't have to report numbers for recording demographics or vital signs or recording smoking status. That requirement that you provide a clinical summary at every visit has been, you don't have to report on that anymore. As well, you do not have to submit reports on structured lab results or the fact that you're able to create a patient list by diagnosis or the fact that you send patient reminders. The summary of care measure has been simplified. There used to be 3 measures for that. They've taken out measures 1 and 3. We'll talk about the remaining one when we go over the remaining objectives. Part of Stage 2, there was under the menu set the option for electronic notes and imaging results. Those have both been taken away as well. So I do want to point out that even though they have, remember that one of the reasons why they simplified the reporting is because they wanted reporting to be easier for providers, and many of these things were redundant. So even though I'm telling you you're not going to have to report on demographics and vitals and structured lab results and smoking status, for example, as you'll see when we go through the objectives, that information is still going to be required for you to be in your EHR in order to meet other objectives. So they just felt like it was duplicative because it's already required to be a part of the other objectives, so they're not going to make you attest to that individually. So I did want to point that out because in some of these cases, obviously you still are going to need to be capturing that information in your EHR. But we're not going to have to run a report for it anymore. We're not going to have to test for it individually. That's the point of this slide. So I'm now going to review what the 10 objectives are that are remaining. So for 2015, objective 1 is the protective patient health information objective. This is what we know as the security risk analysis requirement. So everybody is required to update or do a security risk analysis for 2015. It has to be done during the calendar year. So don't forget to do that. If you need any assistance with that, obviously the security risk analysis has more to do than just your software itself. It's taking in all the HIPAA requirements in order to be in compliance with that. So your policies and procedures, the training that you've done with your staff on how to handle breaches and things like that, as well as your physical safeguards, like do you have locks, do you have alarm systems, and things like that. And then, of course, your technical safeguards, and that's really where a lot of the times the EHR is affected, whether you're using passwords, if you're requiring passwords to be reset, and you're using access levels appropriately, and you have firewalls in place. So some of it goes even outside of the EHR to the technical requirements. So make sure that you are conducting your security risk analysis. Just a reminder on that, you're not required to be 100% meeting every part of every requirement under it. It just means that you've reviewed it, you know where your weaknesses are, and you have an action plan that you're actively working towards in order to make improvements. So you need to have documentation on what you did, and of course we are, because it really encompasses more than just even your software and IT, we are not the experts on doing a security risk analysis. However, we are partnered with a company that we can get you special discount pricing and everything if you would like assistance from a professional on how to conduct that security risk analysis. I know that it is part of the Meaningful Use program. It's also a requirement of HIPAA, and beyond that, I look at it as an insurance policy because patients are very sensitive to, you know, one of the big scares that they have about the whole EHR program and in general is that their data is going to be susceptible to, you know, internet hackers and things like that. So you have to put policies and procedures and technical safeguards in place to protect that patient data. And that insurance policy means that if you're doing a proper security risk analysis, one, the likelihood of a breach is going to drastically decrease. And if there is a breach and you're called into question, that security risk analysis is your protection, your insurance policy against lawsuits that can and will take a practice out of business. So enough said about that. That requirement still remains. There are no exclusions to that. So it's just a straight up requirement. Objective 2 is called the clinical decision support. And you have to, there are 2 measures within this one, and you have to satisfy both measures. The first measure states that you need to implement 5 clinical decision support interventions that are relative to your practice, of course, but at least 4 of those quality measures need to be associated to one of the CQMs that you're reporting on. So there are, you know, if for any reason you're not able to find, if you're not able to find at least 4 that are related to a CQM measure, then you are able to still attest to this one. So there is some leeway on this particular measure as far as like meeting it. We can go into details, and of course you can always read up on that in the final rule. But most of the time I think practices are using, this is a very subjective one, so it is a yes-no attestation. There's no report that we can run for you to show that you are or that you're not doing it. It will be up to you as a practice to document what you're doing. A lot of times people look at this as the alerts that come up in the system that intervene to help you provide quality of care to your patients. So most practices are probably using health maintenance as an alert, maybe that they're overdue on a colonoscopy or a mammogram or an immunization. All those things qualify as clinical decision support. They are not the only things that qualify for clinical decision support. This is one of those areas that as a practice you're going to have to review and determine how you're going to implement this. It can be conditional logic that's in your progress notes that may prompt you to do smoking, tobacco intervention because the patient's a smoker, or a whole variety of ways that you can meet this particular measure. So just make sure that you have documented, you've chosen 5 that are of high priority to your practice. At least 4 of those, if you're capable of finding 4 that are relative to CQMs, you need to at least have 4 of them that are relative to CQMs, which are your clinical quality measures. And make sure, of course, that all that is enabled. You have a way to track compliance to the rule and that you've got that documentation on hand. So there are no exclusions to Measure 1. However, there is an alternate exclusion that if you were a provider that was scheduled for Stage 1 in 2015, then under Stage 1's original rules, you were only required to implement 1 clinical decision support rule that was a high priority to your practice. So you can, instead of reporting that you've implemented 5, you can use that alternate specification to say, I didn't do 5, but I was only required this year to do 1 originally, so I'm going to test that I have 1 clinical decision support rule in place. And that is for 2015 only. So again, if you're scheduled for, look ahead to 2016, if you're only reporting 1 this year, make sure that you have 5 in place for next year. The second measure is simply that you have your drug and allergy interaction checks turned on for the entire EHR reporting period. So again, make sure that there is one exclusion to this measure, and that is if you're a provider that writes fewer than 100 medications orders so you've prescribed less than 100 times, then you're excluded from this particular measure. Otherwise, again, it's up to the practice to keep that supporting documentation because this is a yes/no attestation so that you're showing that it was turned on for the entire reporting period. Remember that your clinical tools updates, if you're one of our Medisoft Clinical or Lytec MD users, those need to be updated and cannot expire during your reporting period. Otherwise, that functionality will be turned off, so make sure that you stayed up on those updates and everything else, and you should be good to go on that particular measure. All right, Objective 3 is the Computerized Provider Order Entry Objective, also known as CPOE. So there are 3 different measures for this one, and you must attest to all 3 measures and satisfy all 3 measures. Either satisfy it through you were able to obtain that measure, or satisfy it through the fact that you were excluded from that measure. So they look at each one of those individually. In other words, if you can be excluded from one measure, that doesn't exclude you from the whole thing. It just excludes you from that one measure. So for Measure 1, it simply says that more than 60% of your medications ordered were done using computerized provider order entry, which just means that you're entering in those medications into your EHR. You're ordering them through the EHR. The exclusion to that is if you write fewer than 100 medications, and then for 2015 only, and I apologize, it looks like I must not have updated that particular part of the screen, but for 2015 only, I believe there is an alternate exclusion so that you're back down to 40% of medications ordered. Because under Stage 1, you were actually only required to do 40%. So if you're not quite at 60% on your percentages, then you could still, if you're in Stage 1, attest under that alternate exclusion and be able to meet that particular measure. All right, for Measure 2, this is looking at your laboratory orders. So you must be using your order entry section of your program in order to meet Measure 2 and 3. And this just says that for more than 30% of your labs ordered, you did it using computerized order entry. So make sure that you've been using that functionality in your EHR to record the labs that you ordered. Now, this does not mean that you have to send those lab orders electronically. It just means that you're recording them as an order in your EHR. So for this measure, you are excluded if you write fewer than 100 lab orders during the EHR reporting period. And if you were scheduled for, this is one of those that does fall across 2 years, the very minor exception that in 2015 and 2016, if you were scheduled for stage 1 in those, either one of those years or both of those years, you can claim exclusion to this measure altogether because it was not a requirement of stage 1 as it was originally written. It was only a stage 2 requirement. So be aware of that. And then this measure 3 is very similar, except it's just it's 30% of radiology orders were entered using computerized order entry. If you write fewer than 100 radiology orders, you can be excluded altogether. And if you were scheduled for stage 1 in either 2015 or 2016 or both, then you can be excluded from this measure. You can claim exclusion because you were not originally scheduled to have to do this particular requirement. All right, electronic prescribing. So in this particular measure, it just says that it's still 50% of permissible prescriptions written were written electronically, and they were queried for drug formulary transmission. So they kind of combine two things in one. That used to be a menu objective to have the formularies. It's just part of this particular objective. So again, I would keep supporting documentation that you have formularies turned on and that that's part of your product. But you need to be e-prescribing permissible prescriptions, so they're still excluding any of the scheduled or narcotics from this particular measure. If it's something that can be sent electronically, they want to make sure that you're sending at least 50% of those electronically. You can claim exclusion in general if you write fewer than 100 prescriptions. You can also claim exclusion if you're in an area where you don't have a pharmacy within 10 miles that is able to receive prescriptions electronically. So if you're limited, in other words, you can be excluded on that as well. And then for providers that were scheduled for stage 1 in 2015 only, they are going to allow you to lower that threshold down to 40%. So because it was a lower threshold for stage 1, they're still going to allow you to test as long as you're, you know, if you're below 50, you can claim that exclusion if you're above 40%. All right, health information exchange. So this is kind of a big one here that was changed. This is the whole summary of care record. So if you refer a patient to another summary of care, then you're required to use the EHR to create that summary of care record, and you must transmit that summary of care record to the receiving provider for more than 10% of transitions of care and referrals. So you are only excluded from this measure if you are a provider that essentially transfers care or refers patients less than 100 times during the reporting period, which for many specialists, that this may very well apply to you, that you're going to be excluded from this particular measure. The alternate exclusion is for anybody that was scheduled for stage 1 in 2015 only. You can claim exclusion from this measure just based off of that, because it was not a stage 1 requirement, it was a stage 2 requirement. But again, be prepared to handle this for 2016. I know that for some of you this may be a pain point, especially the 10% transition of care needing to be sent electronically, because it's going to require that the person on the receiving end is capable of receiving those summary of care records electronically. And this happens to be the one that I jumped on to make comment on, because as I've seen it working with practices, especially my primary care providers, this is a pain point for them, because in one hand we probably have people on this call that are specialists that write less than 100 referrals, and therefore you've chosen not to set up your direct email accounts, which are, the way that the system is going to send these electronically and record or give you credit for having done it. So that poses a problem for our primary care providers, because if you as a specialist are excluded from this measure and you're not enabling that functionality in your EHR to receive those electronic transfers summary of cares electronically, then you're making it harder for your primary care associates to send those referrals to you electronically. Obviously, you're not giving them the option to send it to you electronically. So we have a lot of primary care providers that are in tough position right now because there's not enough people that have enabled functionality. So if you want to be someone that increases your referrals from primary care providers, I would go ahead and get that enabled for your practice, because you may find that you're going to get a lot more referrals because they're looking for someone that they can send at least 10% of their referrals to. So we can help each other out by everybody enabling that functionality. And under CMS's comments, that's why they kept this as a requirement, is because they're really trying to move the industry forward to coordinating care better through sending these electronic summary of care records. So I am going to stop for a moment on this one to give a little bit more, to look a little bit closer at what the summary of care requirement is. If you have not been, participating in this thus far, because it was a stage 2 requirement that, if this was your first year for stage 2, then it's important to look at what CMS has defined as a summary of care document and what information must be made available in it. So when I said before they've taken away some of the duplicative requirements, you can see in here that a lot of those requirements are still required because they're required in order to capture a full summary of care record. So what CMS has outlined is if the provider knows it, if that information is available to you, then you must include this information in your summary of care record that you're sending to your referring providers, or in instances where you're doing a transfer of care. So you must have the patient's name, you must have your practice name and contact information. Those two are pretty easy. You must have your procedure. So you should be capturing in your EHR, in your procedure list, the procedures that are being performed for your patients as structured data. In other words, it will not transfer to the in the summary care record if this information is not captured as structured data. So your problem list, your procedure list, all that is where it's captured as structured data. You must have the encounter diagnosis. So again, that must be on one of your problem lists in order for that information to transfer. It's not enough for it just to be noted in your notes. You must be capturing immunization. So as structured data in your health maintenance, that's where the immunization information would pull from. So again, not just in your notes, you need to have it as structured data. Your laboratory test results. So even though they've taken away the requirement to attest that you have structured lab results, your laboratory test results are only going to be included, and that is information that's typically known to you if you're the one that's ordered and received those results. It needs to be as structured data in your lab data tables. Your vital signs, you're still required to capture that same information to include it in the summary of care. You're also required to have the smoking status. There are a few things that you have functionality right now that you may not be utilizing. So in your programs, you do have the ability to record the functional status, including activities of daily living, cognitive and disability status. That is in your EHR right now, so make sure you're utilizing that section if you're doing summary of care records. You also must include demographic information that has to have that preferred language, sex, race, ethnicity, and date of birth. Another area that you may not be utilizing in your EHR right now is the care plan. So you are required to send the care plan, which would include goals and instructions. So again, it's not enough to just have it as part of your documentation. You need to be recording it as structured data in the care plan section of the patient's chart. You're also required to include care team members, including the primary care provider. So if that information is known to you, then that information needs to be recorded in your EHR under the care team in the patient's chart. And then in addition, you need to record the reason for referral. So again, that's what CMS has outlined as the requirements for the summary of care record. It might be a good time to review your processes and workflow to ensure that you're capturing all that data in your EHR. A little bit more information on that. Again, this is one of those areas where you need to go and read if you have questions, because there is some additional information or interpretation that can be made. So again, you're not, you can be excluded from certain information from that other list if it's simply not information that your practice collects as a standard part of, your practice. Maybe you're a dermatologist and you just don't do vital signs. You're not required to do vital signs in order to record that in your summary of care record. However, at a very minimum, CMS has defined that it is not truly considered a summary of care document unless it contains these 3 core items, which are the current problem list, the current medication list, and the current allergy list. And they also are requiring that providers verify those 3 lists and make sure that they're not blank before, and that they're up to date before they generate that summary of care document. So hopefully enough said on that. I just wanted to add a little bit more detail because they have, again, in stage 2, that kind of further, this is when this came out, and they kind of really defined what you needed to be capturing and sharing as part of that, and they have held those same standards as part of this final rule. The next objective, number 6, is the patient-specific education. So this particular measure says that patient-specific education resources identified by the certified EHR technology are provided to patients for more than 10% of unique patient office visits seen by the provider during the reporting period. So your only exclusion on this in general would be if you're a provider that doesn't have office visits. And because it used to be a menu set objective in stage 1, you can claim exclusion for this if you were scheduled for stage 1 in 2015 only, just because if you didn't intend to report on this particular menu objective, you can be excluded from it. Now, patient-specific education is something that's been around as a menu objective since stage 1, and since it was originally introduced back in 2010. However, there was a lot of chatter on this in the public comments regarding this, and I think it's, since that original time, CMS has offered more information. So I do want to review that because I want to make sure that you guys are, if you haven't touched your configurations or your workflow or anything from the beginning, it's a good time to look back and see how you're meeting this particular measure. There was a lot of comment or concern about printed materials. So if you have handouts that, are already brochures or whatever sitting around in your office, do those things, are those considered part of this particular objective? If you look at more closely at the wording that CMS used, they specifically said in this objective that these resources had to be those that were identified by the certified EHR, and that resources that are not identified should not be counted in this particular measure. So they went on to kind of address those questions and concerns and further clarify it. They went on to say that they're not in any way wanting to limit providers from providing paper-based education materials if that's beneficial to your patients in your practice. They're just saying that you shouldn't be counting those, or you're not required to count those as part of this particular measure, because it really does not, it really falls outside of the definition of the program for this particular measure. So what they have said is, everybody, I believe, should have the patient education module as a part of their product. And so as part of certification, in order for your product to be certified, that patient education module was what was put to the test. And the way that the program suggests suggests patient education materials through certification, we have to be able to go to a patient's problem list and say, hey, this patient has diabetes, and what patient education material can you suggest for me, that type of thing. So from the patient's problem list, from their medications, and from their lab list, the EHR has to have the capability to identify patient education materials, and your products do. They have further stated, though, that you're not required to use the patient education materials that are, suggested in your systems. If you use an external system, like if there's a website that you use outside of the system, then it's okay if you're using those external sources. Your program still has the functionality for you to go to the problem list or anything else, or sometimes you even might have things embedded in your templates because you have a specialty-specific, a problem-specific template, for example. Those are all, that's fine as long as the EHR is the one that's suggesting that material to you. So if you are linking to an outside website to find those education materials, I just wanted to bring all this up because this is one of those areas that you might want to review your current policies and procedures to ensure that you're being compliant with CMS's definitions on that. So by design, your programs, if you're printing any, which you are allowed to print those education materials from the product to, of course, give to your patients. You don't have to deliver them electronically. All that CMS cares about is that the EHR has the capability of identifying the information. They don't care how it's delivered. As long as you are using your EHR in that manner, then you'll be meeting this measure. As far as your reporting goes, if you're ever printing education materials out of your EHR from the patient education module, that should automatically be giving you credit. If you are using any of those external or outside resources, that's when you would want to use that. If you're using LITEC MD or Medisoft Clinical, you can use that dot code in your notes to identify or give yourself credit for having used that external or outside resource on that. And that's the way that you would give yourself credit for having done that through the product. All right, enough said on that particular measure. I'm going to move on to medication reconciliation, which is the number 7. So in this particular measure, you're required to perform medication reconciliation on more than 50% of transitions of care. So where the patient is transferred into the care of the eligible provider. So you are excluded from this measure if you are not a recipient of any transitions of care during the EHR reporting period. And as an alternate exclusion, because this was a menu objective under Stage 1, if you were scheduled for Stage 1 in 2015, you can be excluded from this measure if you did not intend to use that as one of your menu objectives. So a little bit closer look at MedRec. I don't know why this one is so confusing, but oftentimes I know that as trainers, when we start to talk about transition of care, we get these blank stares, and it's a point of confusion to people. So, and I think in general, the way this objective was written, if you look at the definition of the objective, it says that an eligible provider that receives a patient from another setting of care or believes an encounter is relevant performs medication reconciliation. And I think that whole section there, or believes an encounter is relevant, put a lot of leeway in providers' hands. But if you look at the actual measure, what they want you to report on, they only want you to report medications reconciliations that were performed on the actual transition of care in which the patient is transitioned to care. So I'm going to look at that a little bit closer because there was a lot of comments on this. In Stage 2, CMS really came out and defined it a little bit. You know, they put better definitions out there of what they were intending and how to record this particular measure than they did under the menu set in Stage 1. So there was chatter on the comment period for the finalized rule in Stage 2 to see if CMS intended to limit the denominator to just those transitions of care with this final rule, and CMS came back and confirmed that they are going to maintain those denominators as they defined them for Stage 2. So again, if you configured this way back in Stage 1 under Stage 1 rules, you may have decided you may be recording your transitions of care or who needs a med rec and including in your denominators people that are not truly a transition of care. So I think it's worthwhile to revisit this and look at the definitions that CMS has put out there. So transition of care, and this is the one that people have a lot of confusion over. Transition of care is defined as the movement of a patient from one clinical setting to another. So CMS gave the definition, the examples of like an inpatient, outpatient to a physician's office, or from a physician's office to a home health or rehab to a long-term facility, so on and so forth. So any of those settings or from one physician to another physician, all of that, like a referral is considered a transition of care, as well as if you're actually transitioning them out, like you're no longer going to be providing care for a patient. The other easy one to understand is if a patient was seen in the hospital and then that hospital is referring them back to you as their primary care provider, for example, then that would also be considered a transition of care. So, but at a very minimum, so at a very, very minimum, even if you don't want to try to figure out every patient visit whether or not it was a transition of care or not, they're saying that if a patient is new to your practice, they should be counted in the denominator. And if a patient shows up to your practice and they have a summary of care record from another physician, they should be counted in your denominator. Everything else above and beyond that is up to you to determine, but at a very minimum, those must be counted. Now, I think where it got confusing is that in the objective they said they used this word, or if it's a relevant encounter, as part of the just the general objective wording. But in stage 2, CMS went on to say that, hey, we understand that if a patient hasn't been there for a long time in your office, you might feel like it's relevant. Or if there could be a whole bunch of reasons why you might feel like it's relevant to do a patient reconciliation. However, they want you to note that just because it's relevant does not mean that it should be included in the numerator and denominator of that measure. In fact, it should not be included. So again, this is one of those areas that if you haven't looked at it in a long time, you might want to review your processes. This in particular, when you're looking at your clinical encounters in your EHRs, if it's marked as an inbound encounter, that is what is telling it to include it in the denominator, in the denominator for this particular measure. So there is going to have to be some judgment made, in other words, in order to determine which patient should be included in your denominators. And this is one that if you have questions on it, go and read this section of the final rule, because they review a lot of the comments that were made by the public, and most of them probably have the same questions that you did about this particular measure, and CMS provides guidance and information on how to properly count it for your practice. Okay. All right. Believe it or not, we actually are getting a little bit closer to the end. This next objective, number 8, is patient electronic access. So there are 2 measures for this particular one, and this is one that in a good way was simplified through the whole patient engagement. So for measure 1, it means that 50% of unique patients need to be given online access to view or download their health information. So you're only excluded from that if you don't have it recorded in your EHR, any of the information that's required for that particular measure, any of the information that's required to be made available to your patients, or if you live in an area where there is simply not you don't have the internet access, like the population of patients just doesn't have sufficient internet access for the area. So really, that doesn't leave most of you a lot of leeway. Really, by and large, I've seen that everybody has needed to meet this particular requirement. I know there's a lot of talk out there about age, and again, in the comments and things, CMS addresses that. They don't feel like a patient's age, like if you deal with mostly an elderly population, is a reason to exclude you from this measure, because they've also stated that it doesn't have to be the patient themselves. It can be an authorized representative of the patient that's given access. So if you are dealing with a much elderly population, if they have other, people that are helping them with their care, it's fine to give them access to that information as well. So measure 1, you need to be giving 50% of, that just means you're giving them access. You're not liable at this point for what they do with that access, but you are giving them access for measure 1. Measure 2 says that for 2015 and 2016, just one patient seen by the provider needs to actually log on to view their information. So instead of that threshold that we had before, that it needed to be 5%, they have removed that requirement for 2015 and 16 to say as long as one patient gets on. And you know what? It would not be hard for you to sit down with one patient in your practice and show them how to get their information online and easily meet that particular measure. So that's what they've given you for 2015 and 16. Looking ahead to 2017, they are bringing that 5% threshold back. So, but for the next 2 years, it just needs to be at least one patient, because they want you, as you're spending the time to give them online access, to start building that as a standard, so that it's encouraging people to get on and view their information. So they feel that by 2017, as long as we're granting everybody access, we're encouraging everybody to start going online, that we should be able to hit that 5% by 2017. So same exclusions apply for measure 1 and measure 2. If you're excluded for any one of those reasons, you can be excluded from both of those measures. Alternate specifications. Anybody that was scheduled for stage 1, the online patient portal was a requirement of stage 1, so you're not excluded from that. However, in 2015 only, you can be excluded from the second measure of having the patients actually get on and view their data, because it was not a requirement under stage 1's original definitions. All right, so let's look again at the required information of what they want you to have online. That would be the patient's. It's very similar to the summary of care records. One thing to note that all this information needs to be made available to the patients within 4 business days. And the other thing to note, obviously, if you're putting this information in your EHR and you're giving them online access, that will be made available to them. So just by way of putting it in your EHR, we may see some changes coming to reporting as a result of this, because right now your certified EHR did not have to be certified in order to prove that it was done within 4 business days. But in the next few years, we may be seeing some changes to that. So I just want to give you a heads up on that. However, in this particular measure, they have given providers leeway to say that, hey, this is what we're requiring. However, it is up to the provider's discretion if they want to withhold some information because they feel like it might be detrimental to the patient, so that it's not going to provide good care for the patient, which I have encountered some instances where providers that maybe are dealing with elderly patients might not want them to get online and see some particular information, like that they have dementia or something like that, that might cause trauma to them. I don't know. There just might be very well instances where there might be a reason to withhold certain information. So, but the list that they have provided says you need to give patient's name, the provider's contact information, their problem list, their procedures, again, their lab results, their medications and med histories, current medication allergy list and history, their vital signs, smoking status, demographic information, their care plans, including their goals, and also any known team members, so their care teams. All that needs to be in there. You can see that it doesn't require that you're giving them their progress notes or a bunch of other stuff. That's all up to your discretion. Anything above and beyond that, this is what they've outlined that you should be making available. So if you do have the web portal enabled, I'd encourage you again to review to make sure that you've got the right things enabled to grant access for your patients. All right, Objective 9, secure messaging. So this particular measure, it increases each year. For 2015, you just have to have the ability enabled for your patients to send you a secure message. So that needs to be enabled for the entire reporting period. So as long as you've turned it on so that your patients can message you and send that to the provider, you're good to go. In 2016, they're saying, hey, at least one patient has to actually send you a message. And then in 2017, they increase the threshold to say that more than 5% of patients need to send you a message. The exclusion is just that if you are a provider that has no office visits, or again, you're in an area where there just might not be internet access available to your population, then you can be excluded from that. For 2015 only, since patient messaging was not a requirement for stage 1, you can be excluded for this for stage 1. But keep in mind, looking forward to 2016, you want to make sure that you have this functionality enabled before January 1st, because you're going to need to have it turned on for the entire reporting period, which next year is the entire calendar year. All right, objective 10, public health reporting. This is our last objective to look at. There are 3 measures to choose from, and providers have to meet at least 2 of the measures. This one, in this particular case, exclusion, so if you choose one of the 3 measures and you're excluded from it, then you have to actually choose the other 2 measures that you could attest to. So you cannot claim, choose one because you're excluded and count that as one of your measures. If you are excluded from 2 measures and there's only 1 left that you can actually attest to, you have to choose the one that you can attest to. And if you are excluded from all 3 measures, then you can be excluded from this altogether. All right. So in short, if there's 1 that you can do or 2 that you can do, you must choose those. Otherwise, you can't claim exclusions and still meet this measure. So for the public, these ones are big enough that I had to separate them out into 3 different slides. So know that you're going to have to choose 2 of these 3 options. The first one is the immunization registry reporting. So they have changed this definition a little bit because they're now using the wording, an eligible provider is in active engagement with a public health agency to submit immunization data. We'll talk about active engagement in a little bit after we review 3 measures. You can be excluded from this measure if you do not administer immunizations to any population for which the data is collected by your jurisdiction. So if you happen to even do an immunization, but it's not one that your jurisdiction collects information on, you can be excluded from this. If you do no immunizations at all, you can obviously be excluded from this. The other ways to be excluded from this measure is if your jurisdiction does not have an immunization registry that's capable of accepting the information electronically. All right. As an alternate exclusion for 2015, since this was not a requirement under stage 1, you had to actually choose one of 2 requirements. If you were scheduled for stage 1 in 2015, they are allowing you to lower the number of measures that you have to attest to. So instead of choosing 2 measures, you can choose just one of these 3 measures. Kind of the same rules apply. If you can only do one of these measures, you have to choose the one that you can do. You can't just claim one and say, well, I met it because I'm excluded from this measure, when in fact you could have done another one. Okay, so just be aware of that. So that is the syndromic surveillance data option. So again, they've changed the definition a little bit to say that you just need to be actively engaged with a public health agency to submit syndromic surveillance data. You can be excluded from this one as well if you're not a provider that collects any syndromic surveillance data that's required for your jurisdiction. Or if you are in a jurisdiction where there is no public health agency that's capable of receiving this information electronically. The alternate exclusion, again, on this is that you just only have to choose one of these 3 if you are scheduled for stage 1 this year. The third objective in this measure, and this is a little bit different because this was a menu objective under stage 2, but they've thrown it in here as part of this public health objective. The third option is that if you can submit data to a specialized registry, then you need to be actively engaged in submitting that data. And again, if you don't treat any conditions where that might be collected by a specialized registry in your area or your jurisdiction, then you can also be excluded from this measure. Or if the specialized registries are not capable of receiving this, then you can also be excluded. Same alternate exclusion, you just had to choose one of these three if you were scheduled for stage 1. So a big question that we always get, what is a specialized registry? So specialized registries can include, but are not limited to, birth defect registries, chronic disease registries, traumatic injury registries, registries that are focused on healthcare-associated infections, or registries that enable knowledge generation or process improvement regarding the diagnosis, therapy, and prevention of conditions that affect a population could also be considered. So in general, there's a lot of options you might have out there for specialized registries. So let's look at what it means to be actively engaged. You just have to be able to show that you're in one of these 3 phases. So any one of these 3 phases would qualify you for those measures of being actively engaged if there is one of those public health measures that you can attest to. And again, you should be attesting to 2 if you're capable, unless you were scheduled for stage 1. So the first option is that within 60 days of the start of your EHR reporting period, you have completed your registration to submit data. So you've contacted the public health agency or their registry in order to fill out their application, and you've submitted that application to say, we intend to submit data to you. Of course, that agency would have to have capability of receiving it electronically. Otherwise, you would already be excluded from that measure anyway. So that's option 1, that, hey, we're actively working towards it because this is the first time we're doing it, and within 60 days of our reporting period, we have submitted to start working with this registry or this public health agency. Option 2 is if you've now moved past that stage, you've already submitted, you're already registered, then you need to be actively working towards the testing and validation of electronic submission. So a lot of that, of course, is going to be dependent on the agency that you're working with. Some of them are slower than others, so it could take them months to get back to you. So what CMS is requiring is that if you're in this process and you're communicating with the public health agency, if that agency responds to you and says, okay, we're ready, send your test over, you have to respond to that within 30 days. So if they contact you more than 2 times that you have not responded within 30 days, they do not consider you to be actively engaged with that agency, and you would not be in compliance. Once you've moved past testing and validation and you're in production, then you need to just be simply submitting that data in the production mode. So again, they've changed this to give you a little bit more leeway. So wherever you are in the process, as long as you're actively working towards the next step, then you're going to be compliant on this measure. All right? All right, as far as CQM reporting goes, there are no changes to the reporting requirement. You still must report 9 CQMs across 3 domains. If you happen to not have 9 CQMs available in your EHR to report, then you're still allowed the exception that if you need to report 0 denominators, then you will still qualify for this particular measure. The one thing they have changed on this is that you can attest for any continuous 90 days in 2015. So whatever your reporting period is, I would choose that same reporting period to report your CQM data. Alternately, if you are participating in one of the PQRS programs and you're submitting that data electronically out of your EHR to that PQRS portal, then that requires that you submit data for the entire calendar year. That submitting that data electronically to the PQRS portal for the entire calendar year can also qualify you to have met this particular measure. You have the choice essentially when you're attesting online to indicate whether or not you submitted it through the PQRS portal or whether or not you're going to go ahead and just attest online as part of your EHR attestation for those 90 days. So just so you know, in 2016, 2017, you must report for a full calendar year unless it's your first year. and you still will have the option of either attesting through the attestation website, which if you are reporting zero denominators, that probably is going to be your best bet, or you can report electronically through the PQRS portal. During that time will also qualify. By 2018, everybody must be reporting electronically through that PQRS portal. So that kind of wraps up our 10 objectives. So what do you do with it now? What do you do next? The first thing that you should do is run your reports to see if you already have a 90-day reporting period you can attest for. It's still not too late to attest for this last quarter. So you can, if you can't find 90 days that you're up to speed on for the previous, section of the year, you still have a few months to get your numbers up for this last quarter. So when you're running your reports, though, do not forget to run your CQM reports. I know that there's no thresholds and stuff on that, but it's still a good thing to look at to make sure that you're capturing data in a way that you can attest for measures if you're capable of attesting on those measures. You want to ensure that you're getting credit and that your reports are configured and that you're capturing data in your EHR in a way that your CQM data will be available to you accurately. The other thing you should be doing is, if you have not already done so, make sure that you're done your security risk analysis for 2015. Regardless of what 90-day reporting period you choose to attest for, you can do the security risk analysis anytime during 2015. So even if you're going to use a prior time and you haven't done your security risk analysis yet, you can still do it before the end of the year and still test for that prior 90-day reporting period. Make sure that you have supporting documentation for any yes-no measures. So again, auditing is not a question of if, but a question of when. Everybody at some point is very likely to get an audit the way that they've outlined the auditing system. And in some cases, now you're not even able to submit your attestation without proving some of this audit information. So for anything that we have a report for, you're going to have that report to back up your numbers, right? But there are attestation questions that are simply, yes, I did it, or no, I didn't, and we have no report to provide for you to show whether or not you did it. So it's up to individual practices to keep supporting documentation, such as screenshots is usually what CMS recommends for you. So there are measures in here, like the security risk analysis. You would want to have that documentation in place. Your clinical decision support, you would want to have documentation of the 5 measures that you were doing, screenshots of how you're capturing and tracking that information. Drug and drug allergy interaction checks, that's required to be turned on the entire reporting period, so we highly encourage you to have screenshots at the beginning and the end of your reporting period, if not in between, that show that that functionality was enabled through the entire reporting period. Same for drug formularies. You would want to have screenshots for that information as well to back up that claim. And then for your public health reporting, you want to keep documentation of what you were doing to be actively engaged. So any emails or documentation, your registration, communications with those registries would qualify for supporting documentation for that. And then lastly, look ahead. Make sure that you're looking ahead to 2016 because we've only got 2 months left. So you want to make sure that anything that has to be done and enabled for the entire reporting period for 2016, that you're already on the ball to make sure that that functionality is configured and turned on and that your staff is trained on how to properly do that. All right, so I'm going to last end with the resources that are available to you. This is probably the best resource that you can go to, cms.gov/EHR Incentive Program. You can't see it maybe too clearly, but down here at the very bottom, they have tip sheets and overview fact sheets, and they have promised to update this with a new table of contents and everything else for this modified stage 2. So visit this website, and it will typically answer most of the questions that you may have regarding your attestation. Of course, you also want to go here and make sure that you are registered. There's information on hardship and all kinds of things on this website. It's the #1 source that you can go to for any of your questions. And as well, CMS's contact information is there as well. the Federal Register. I would highly encourage you to, if you have questions on any of these measures, the definitions, the applicable, the way that it's applied in practices and things like that, go look at the final rule. Yes, it's 752 pages. However, a good portion of that deals with stage 3, and for each and every one of those objectives, CMS has commented on what they proposed, what the public response was, the questions that the public had, and what CMS's responses to those questions are. I included some highlights in here on, some of those, more detailed information regarding the measures, but you can, usually each measure is just going to have a few pages worth of public comment and CMS responses on it. It's well worth the time to review that information to make sure that you understand it clearly and are making decisions about how that applies to your practice, because ultimately you'll be the one that's responsible for that interpretation. The other thing that is super helpful, if you go to the CDC, like a lot of those things, especially when it comes to public health registries, you want to know what's available for your jurisdiction. Well, if you go to the CDC's website for EHR Meaningful Use, they have a ton of information up here, including links for every single state so that you can easily find resources that are available for your jurisdiction. So I'd encourage you to go there. They have a whole frequently asked questions part and a bunch of other great information. And then lastly, ascomp.com/blog. We are continually updating the blog. As soon as we get information, we put it up there, not just industry news, but we're also including training tips and tricks up there as well. So anything that has to do with meaningful use is going to be available on that site as well. And I know that that was kind of rushed. We're right at our 90 minutes right now. So I'm going to go ahead and, take a sip of water, and we're going to open it up for the questions and answers. If you weren't able to stay with us, if you have additional questions, you can reach us at the number on this slide at 888-988-7795. You can also access information on our blog. I'd highly encourage you to subscribe to it, so when we post anything there, like this video that we're going to provide for you, you would automatically get an email of this webinar if you subscribe to our blog. And then also, if you need more one-on-one time to actually look at your configuration or your reports or answer questions for you, we offer meaningful use assessments. So you can contact us to have a meaningful use assessment, and we're happy to work with you one-on-one to help you through this transition. With that, I'm going to go ahead and open it up to, I believe Benson is on with us, so he can, hopefully, if you have questions, then go ahead and submit them. He's going to go through the ones that we have so far.
Yeah, hey, thanks, Lori. Can you hear me?
Yes, I can. Great.
Okay, all right, good deal. All right, thanks for staying on with us, everyone. I know that was a ton of information that Lori just went through. I don't fully understand much of it, but I'm not a doctor either. I'm not worried about it. But we've got a list of questions here, and Lori, I'll just go ahead and ask each one of these, and go ahead and respond. But the first one is from Tanya Strum, which asks, will there be any software updates to run reports according to the modified stage 2?
That will be determined. Right now, CMS has released, with this modified stage 2, they're saying EHRs do not have to recertify. So literally all the measures that are in there, you should already have a report for those particular measures. So especially if you pull up your stage 2 report, you're going to be able to uncheck a lot of those reports. Like, you won't have to check demographics or patient reminders or vitals and things like that. But you should still have reports for the remaining measures. They're just not going to necessarily be outlined as, objective 1, 2, 3, like through 10, like they are right now. They're still going to have the old definitions. So because this is just late breaking news, I have not heard McKesson's response on any of this yet. But the good news is your product as it stands today still already has the capability of giving you these numbers. It will be determined whether or not there's going to be a new reporting module released. I'm sure that for the 2015 certified version, obviously that will be the case because we'll be moving to everybody will be moving to stage 3 regardless of when you started. And with that certified version, it will have a new set of reports in it.
Okay, I think that was a pretty thorough answer. The next question is just like a confirmation of some information that you presented. So just to confirm,
sure.
If a physician was scheduled to begin to be stage 1 this year, second year to report, they will report the same as a provider that were scheduled to report as stage 2? Does that make sense?
That's correct. So they've done away with the individual definitions based on when you started the program. They're just saying, look, everybody's in what we call a modified stage 2. Everybody's going to report to these 10 objectives. So if you are somebody that was scheduled for stage 1, you can go ahead and run your stage 2 reports, and you should be able to line up the measures to the new objectives to see where you're at. And then if there are any that you're not meeting the measure on, then anything that was required for stage 1 that was not in stage 2, anything that's now required, they're letting you go back to the stage 1 requirement for 2015 only. The only exception to that was just for labs and radiology. They are going to extend that one over to 2016 as well, but everything else, if you were working towards stage 1 this year, even though they're going to require you to attest on this new set of 10 objectives, they should, in most cases, not be new to you. You just might have lower thresholds and maybe a few new things that you weren't going to have to do in stage 1. And you will have the option to be excluded. I'm sure that as they're updating that website right now, what they did under the flexibility rule last year when they updated the website is they recognized if based on when you started the program, if you might be a provider that can claim extra exclusions. So I imagine in their website, even though they haven't released any specific information about that yet, that as you're attesting, it's going to open up alternate exclusions for you to say, hey, I know you're requiring me to, have done 50% or 60% of prescriptions maybe, but under stage 1 I was only required to do 40%, so I'm going to attest under the stage 1 rules for 2015. Does that make sense?
Yeah.
If you have more questions on that, go ahead and resubmit an extra question, but hopefully that answers it. Everybody's going to see the same 10 objectives when you go to a test. You just might get alternate exclusions available to you if you were scheduled for stage 1 this year.
Okay, so on the same subject, and I think you answered this, but another question was, if you're a new provider, can you attest for the first time this year?
Absolutely, yes. If you're a new provider, you can attest for the first time this year. Under the EHR program, if you're attesting under Medicare, then you're no longer going to qualify for incentive. However, if this is your first time to attest, you can still avoid the 2016 and 2017 penalties by choosing to participate. And it's going to be the same 10 objectives with alternate exclusions if this is your first year.
Okay. All right. So now we've got a couple kind of more technical questions. One of them is it asks what function then gives us credit for Objective 8, Measure 1 in the EHR.
Okay, let me see if I can get back to what 8 was, because the new numbering is still new enough to me. Okay, so Objective 8 was the patient electronic access, and Benson, what was the question on that one, Measure 1?
Yeah, sure. What function then gives us credit for Objective 8? Measure
What function gives you credit? Okay, so if you are registering your patients for WebView, then you are getting credit for that. So if a patient comes into your practice and you're giving them online access to WebView, if you're LITEC MD or Medisoft Clinical, or if you're on Practice Choice, if you're giving them access to the patient portal, then you are qualifying. So that's all you have to do. Give them their username and their password and where they need to go to log on to view their data. So you would need to have the patient portal enabled if you're on McKesson Practice Choice, or for our LITEC MD and Medisoft Clinical users, you need to have WebView up and active, and you need to be registering your patients and providing them that information.
So is that the only function then? So if you don't have WebView, then you're not able to meet?
Correct.
This?
Yes. WebView is the online portal, so that is what allows patients to get online, view their data, download it if they need to, or transmit it to another provider. That's how we meet that definition.
Okay. All right. So this next question I think might be pretty related to the first one, but
okay.
it just asks what report for clinical, will the report for clinical be updated? When and how will we get it?
Okay, so right now we do not have, CMS did not require that you update, that we recertify or update the software. Obviously, since we're so late in the game, I think that was a good judgment call on their part, because if new report need to be written or anything like that, then our time to deploy it and test it and everything else is very short in order for you to be able to test for 2015. To date, I have not seen McKesson's response to this modified version. So I do have a VAB meeting, which is, a product, I'm on the product advisory board for our products, and we do have meetings that are fast coming up where I'm sure this will be a hot topic, so I may be getting information sooner than later to pass down. But I'm going to reiterate, you do not need an updated report in order to attest for 2015. You are going to have to look at, when you run your report, you're going to have to line up the measures. So forget the numbers that are in front of it right now. You're just going to have to look for the measure that says patient education and check off to run that report. You're going to have to look for the measure that says, electronic prescribing or CPOE. So you'll just have to look at the definitions individually and check those off. But again, they did not change any of the requirements for these. They just took a bunch of requirements out. So you have reports today that will give you the numbers.
All right. Yeah, that makes sense. Okay, so this last question I think is related to Objective 8, Measure 1. Again, it's asked by the same person, but does the patient have to do anything to get credit for it? What does the patient have to view in order to get credit for? I think it's related back to that Objective 8, Measure 1.
Yeah, so Measure 1, the patient doesn't have to do anything. It's on the practice. It's your responsibility to register them for that, for WebView or the patient portal, and to provide that information to the patient so that they can go online and access their information themselves. Measure 2 says that that for 2015 and 2016, just one patient from your practice that was seen during the reporting period needs to actually get online to view their data. And again, an easy way to meet that measure is pick one of your patients that's in the practice. When you register them, help them log on and see their information, and you will have met that measure.
Just one patient? Just
one patient. So it used to be 5%, and I know there was a big uproar about that. So they lowered it for 2015 and 16 to say just as long as you have one patient log on, then you're going to attest. So you can attest. And that one I believe is going to be changed in the attestation to it's just a yes/no question. Did you have, at least one patient log on, and you will have a report that will show you how many patients have logged on, so that will be your supporting documentation to prove that you had at least one patient. 2017, it will again increase back to the 5%, but for 2015, just help one person get on and you'll satisfy that second measure. Okay,
well I think that's pretty doable then. There are No other questions. Just one of the attendees did just want to point out that they did have an audit. They had an audit last year and they passed, and wanted to thank us for helping out with that. So.
Absolutely. We've actually had a number of our practices that have been audited, and I think that's why I reiterate that it's not an if you're going to be audited, but it's going to be a when kind of question. I think that industry-wide everybody recognizes that. The number of audits they're doing a year is, and the number of years that you can be audited really opens the door wide open for you to be audited at any point. So thank you for sharing that, because it is so important that you're keeping your supporting documentation for in case you are audited, so you can pass with flying colors. And by and large, all of our providers are passing those audits. They're doing a great job. We have had a few, though, where supporting documentation was not, well, we have had instances where it has been very questionable. So again, we're here to help you, but we can only go so far in what we can provide to you as a practice. So make sure that you are reading, interpreting, and understanding these measures, because ultimately you're going to be the ones that are going to be answering to CMS on them. So.
Okay, well there aren't any other questions, so I think that covers it for everyone.
Okay.
Yeah.
Well, thanks for joining us today. Again, we'll be making this information available to you through the blog and our YouTube channel. Look forward to hopefully many practices successfully attesting for 2015. If you need additional help with anything, if you have additional questions, you want to spend some one time with a trainer, absolutely give us a call, and we're happy to set up a meaningful youth assessment. If not for 2015, again, looking ahead to 2016, and I'd encourage you to get that done sooner than later so that we can make sure that you're on track. Thanks for joining us today. We'll go ahead and close the webinar now.
Hey, thanks for watching. Hope you liked the video and found it helpful. If you did, let us know by giving us a thumbs up by clicking on the like button below. If you have any comments, questions, or suggestions, feel free to write those in the comment section below. And if you want to get more helpful videos like this one, be sure to subscribe to our channel. Thanks!